Nearly half of adults struggle with medical debt. It follows cancer patients and their families for years. It robs opportunities and ruins hope for a better future.
I was 25 when I was diagnosed with cancer. But hey, 10 years later, I'm still here. But so is my debt. To be honest, I thought I would have hit some of those milestones by now. Buy a house, have a family, start a business. Instead, I'm living with my cousin in their apartment. Moving on feels impossible because of my medical debt.
Before cancer, we had almost perfect credit. My husband and I were kind of proud of it. Then came my cancer, and we just spent so much on treatment. There wasn't anything left. We had to put everything on our credit cards, and we couldn't keep up. We actually had to file for bankruptcy. I'm in remission, but I'll always be living with debt.
I had to do a GoFundMe for my medical bills. It's embarrassing begging friends and family for money. And they all helped out, but it still wasn't enough. We've got 2 kids, and we're living paycheck to paycheck because all our money goes to climbing out of debt. I guess it is what it is, but we shouldn't be in debt because I survived cancer.
Sometimes it feels like I'm drowning in these expenses and I can't move beyond my leukemia. It's kind of ironic, right? I survived leukemia, but now I'm putting off going to the doctor because I can't afford any more debt. I haven't been to the dentist in 4 years. I just can't afford it. I already work 2 jobs. I can't work any harder.
It shouldn't be this way, and it doesn't have to be. More than 90% of people agree. Elected officials need to protect people with serious diseases like cancer from overwhelming medical debt. Patients deserve better. Join the movement and be the light that banishes the burden of medical debt from patients' lives.
Medical debt is such an important topic, and we're pleased that so many of you have chosen to spend an hour of your time with us today to learn more about it. My name is Ryan Holywell. I'm the Executive Director of Advocacy Communications here at the Leukemia and Lymphoma Society. As many of you know, our mission is to not only cure blood cancer, but it's also to improve the quality of life of patients and their families. And of course, addressing the devastating effects of medical debt has really become one of our top priorities. We know that nearly half of Americans face medical debt. It can prevent them from affording housing, securing loans, even from getting health care. We've done a lot of surveys on this work, a lot of surveys on this issue, and the one thing that patients keep telling us is that medical debt makes them feel trapped. And in fact, those stories that you heard in the video a moment ago, those are real stories from real patients that we work with. But there's hope. There's hope on the horizon. We're going to spend the next hour learning about an exciting movement that's happening across the country to not only protect patients who are currently facing medical debt, but to prevent patients from incurring medical debt in the future. Before I start, I need to mention, if you are a blood cancer patient, a survivor, or a caregiver looking for resources, please contact the LLS Information Resource Center. Our specialists are highly trained social workers and nurses. They can provide you with information on treatment, financial support, social support, and more. You can learn more at lls.org/information specialists or call 1-800-955-4572, and I'll drop that information in the chat as well. If you're inspired by what you hear today and you'd like to join in our advocacy work, please text SPEAK, SPEAK, to 73727, and we'll let you know how to contact your elected officials when we're looking for advocates to speak up in support of the types of policies we're going to describe today. Just a couple of housekeeping notes. Everyone is on mute. We'll have plenty of time for Q&A, so get your questions in there. And this webinar will be recorded and posted to the Leukemia and Lymphoma Society's YouTube page in the coming days. So thank you for joining us. Thank you to Eli Lilly for supporting this program. And now we'll turn it over to my colleague, Lucy Culp, LLS Vice President of State Government Affairs, who will guide our conversation. Lucy?
Great. Thanks so much, Ryan. And thank you all for joining us. I'm humbled by the number of folks we have on the phone today. I think it speaks not just to the severity of the problem medical debt poses in our country, but also to the urgency of finding solutions, really to alleviate the burden it is putting on patients and their loved ones. So earlier this year, we at LLS, along with our partners at Undo Medical Debt, you might also know them as RIP Medical Debt, and ACS CAN, conducted a poll to better understand really both of those things, right? The severity of the problem facing us today and how we might solve it. And what we found was that the burden for medical debt, it isn't just about the unpaid bills, right? You heard it in the video. When you or a loved one gets sick, it's all the ways that impacts our lives, from having to delay or skip care, being unable to save or buy things for our children, being unable to move, or even having to change the food that we eat. But there was hope in what we found as well, because over 80% of US adults with overwhelming support across political parties agree that our country should pass policies that reduce the cost of healthcare and protect people with serious illnesses like cancer from medical debt. So with that in mind, I'm really thrilled to be joined here today with this incredible panel of experts and leaders who are going to share more about the work happening across the country. So first up is Steve Butterfield, maybe give a little wave, who's the Senior Director of State Public Policy at the Leukemia and Lymphoma Society. Maanasa Kona, who's Assistant Research Professor at the Center on Health Insurance Reforms at Georgetown University. And Noam Levey, who's a Senior Correspondent at KFF Health News. We also have Senator Qaddoura, who is an Indiana State Senator from District 30. And last but certainly not least, Chi-Chi Wu, who is a senior attorney at the National Consumer Law Center. So thank you all for offering your time and expertise to the discussion today. I'm, again, just thrilled to have you all here. And we're gonna do this kind of panel style. And Senator Qaddoura, I'll start with you. As a lawmaker in the state of Indiana, really tell us about what sparked your interest for protecting patients from medical debt through policy change that you could achieve in the State House.
Well, first, good afternoon, everyone. I'm honored to be with you, and thank you for hosting such an important topic, which has daunted our nation for the many decades. It's not a new problem, and it is not a partisan problem. What sparked my interest is that in my district and across the state of Indiana, we have many constituents and citizens who struggle with making medical payments, let alone medical debt payments. We experience a costly healthcare system in Indiana and across the nation that struggles or suffers from issues of accessibility, high quality, and affordability. So the issue consistently for me has not just been focused on the debt issue, but rather on the root causes of what leads people to incur medical debt, which is the lack of access to affordable healthcare in our nation. And that continues to be a struggle that has challenged Congress and challenged states for the past at least century. Locally in my district and across the state of Indiana, there are many advocates in that space, including one of my constituents who is the very active and a member of the Leukemia and Lymphoma Society, Dave, and other advocates in the community who work tirelessly to be sure that constituents do not suffer from the issues that the quality of life issues and the legal issues that come as an outcome of medical debt. And for that purpose, I was inspired to introduce my Senate Bill 276, which received bipartisan support. Unfortunately, it didn't move forward for some challenges about the confusion about what the federal government is planning on doing in that space versus states. But we received commitment from a bipartisan commitment from legislators across the aisle to be sure that we reintroduce this legislation in the 2025 legislative session with an intent to move it forward as a good public policy that will protect many Hoosiers across the state.
Thank you. I mean, it's really wonderful to hear about the kind of bipartisan commitment going into 2025. And I mean, you said it, that's what we've seen in the polling as well. There is broad support for this type of action. So thank you so much for sharing that. Noam, maybe I'll go to you next. You've been really reporting in depth on medical debt for some time now. Can you share about kind of what you've been finding and why medical debt is such a problem in this country?
Sure. Thanks, Lucy, and thanks for hosting this event. Yes, we've been reporting on medical debt at KFF Health News with NPR and CBS News for the last 2+ years. In large part because we couldn't not report on this. I think I've been covering healthcare for 15 years here, most of it at the LA Times, but I feel like medical debt is this enormous problem that's just been hiding in plain sight. And in the course of listening to debates about the Affordable Care Act and repealing Obamacare, et cetera, there was never any doubt that people had difficulty affording their medical care. But what I felt was sort of less well appreciated, and is thankfully, I think, now better appreciated, as this panel testifies to, is that when people can't afford their medical care, it's not just a matter of having a bill they can't pay. It has all these downstream effects that your video did a very nice job, I think, of highlighting. Driving people from their homes, keeping people from putting healthy food on their tables, making it difficult to save for retirement. And we hear all this talk in this country now, rightfully, I think, about social determinants of health and how the healthcare system needs to be conscious of all of the other factors that affect people's health. And yet it is debt generated by the healthcare system that in many cases is preventing people from eating nutritious meals, that is preventing them from having stable housing. And it just sort of feels like a problem that we just can't afford to ignore any further.
Oh, sorry. Trouble with the mute. Thank you. That's really helpful. I think it's a helpful context for us. Steve, I'm wondering if you could dig in a little deeper here and share how medical debt is impacting cancer, particularly blood cancer patients, right? The folks that LLS serves and represents.
Sure. Yeah, I think the short answer to that question is badly. It's impacting them severely. You've already heard, some of the examples of, what people experience when they have, this kind of overwhelming debt, delaying or avoiding care, exhausting life savings, major adverse impacts, and in way too many cases actually going into bankruptcy. If there are 3 words that I could have everybody today take away about what the experience of medical debt is like as a cancer patient, it's immediate, it's inescapable, and it's relentless. This idea of it being immediate, from the moment that you were diagnosed with a cancer, your healthcare spending skyrockets. We did research into the cost of blood cancer care in a report a couple of years ago now. And we found that while a lot of that spending occurs within the first few months of diagnosis, it can even be compressed into the first few weeks. If you have an acute cancer, you may go into the hospital for like a lab draw and end up admitted that day. So that spending, spikes very severely, very quickly. So when you have, patients who have insurance that has high cost sharing, high deductibles, it's very likely that they're going to max out within the first few months, if not the first few weeks, of that diagnosis. And that's a really immediate and a really significant cost shock that a lot of people just can't afford to pay. Haunting statistic that keeps me up at night. About half of cancer patients, and there's different studies that find, slightly different numbers, but always around half of cancer patients exhaust their entire life savings within a year or 2 of receiving their diagnosis. So it is an immediate impact. It's inescapable. There's no way to get around this for patients. We mentioned the survey that we did with Undue Medical Debt and ACS CAN. I found that 7 in 10 adults who responded in that survey have received medical bills that they can't afford. cancer treatment is not a singular event. It's not one bill. There's not one sort of, thing that you can manage with, like a payment plan or try to negotiate down. It's a lot of different, discrete, smaller claims that add up very quickly. Lab work, doctor's appointments, chemo infusions, possibly hospitalizations, prescriptions. Some of that's going to be from your primary cancer, might be from treatment side effects, it might be from comorbidities. Patients just don't have the time, the inclination, or the ability to shop around for lower cost care. And even if they do, the magnitude of treating something like a blood cancer is just so enormous that patients are going to take a cost hit no matter what. ACS-CAN did another survey earlier this year, found that about half of cancer patients in that survey reported that they had incurred debt in order to pay for some of their healthcare costs. And there was a 2022 study out in Washington State that found that about 7 in 10 patients, about 71% of cancer patients are going to be more likely to experience adverse financial events as a result of their diagnosis, things like bills and collections, foreclosures. And then it's relentless. You have that immediate hit from diagnosis, you can't get away from it. And those elevated costs are likely to follow you for the rest of your life. Again, going back to the research that we did on the cost of blood cancer care, the costs spike immediately, your spending happens very quickly, but that study also found that it never returns to pre-diagnosis levels. You might have increased monitoring needs for the rest of your life. You might have, additional surveillance needs. You may have, chronic management like pills, meds that you're going to be taking for the rest of your life. And think about that in particular for like a pediatric patient, somebody who's diagnosed and goes through cancer, when they're a kid, those costs may be following them for decades. And, that all adds up, to that same 2022 study from Washington, found that cancer patients are about 2.5 times more likely than the average population to experience bankruptcy. So that's a pretty grim picture. I do think, we're going to talk more today about, the ways that we can start to address this. But, I think it requires a really comprehensive look at, not just sort of managing and treating the symptoms, of costs and how that turns into debt, but also some of the systemic and root causes as well.
Thanks, Steve. I think that's really helpful context. Chi-Chi, I'd love to go to you next. You've really led the charge in thinking through how best to protect patients through comprehensive policy change, even publishing a model bill that states can take up. Could you talk a little bit more about what those policy solutions look like?
Sure. First of all, thank you, Lucy, and thanks to LLS for having me on this important webinar to talk about the topic of medical debt. I've been working on this issue for almost 20 years and have seen the tremendous harms that medical debt can cause patients. Everything from, liens on their home, because medical debt quickly leaves the hands of a provider. If folks can't pay their medical bills, a lot of providers turn them over to debt collectors. And so you're no longer dealing with a provider and the receptionist's office. You're dealing with debt collectors whose main job is just to collect as much money as they can, and using some very heavy-handed tools. So we see things like wage garnishments, liens on homes, lawsuits, bank account seizures, people really financially devastated by medical debt. And one of the biggest pain points we've seen over the years is credit reporting. Medical debt ends up on credit reports for so many consumers. The Consumer Financial Protection Bureau, CFPB, did a study about 10 years ago finding that if you look at credit reports, half of the items on credit reports for debt collection, half are medical debt. I mean, that's huge. Now, the last few years have been exciting because we've seen some progress on that front, specifically credit reporting. A few years ago, the big 3 credit bureaus announced some voluntary changes to remove some medical debt, bills under $500 paid medical debt. But that still left a lot of people with medical debt, and especially people like blood cancer patients, people with chronic conditions or people with catastrophic conditions that had bills over $500. The most vulnerable patients, obviously. And so I know we're supposed to be talking about state law, and I will get to that, I promise. But the exciting development is that the Consumer Financial Protection Bureau has issued a proposed rule banning medical debt from credit reports, banning them just outright. And that is so exciting. And if we can get this rule over the finish line, which is kind of a big if, that will relieve at least one pain point for blood cancer patients and others who have a lot of medical debt. Now, the CFPB is going to need a little help in getting folks over the finish line. So folks need to submit their stories in the form of comments to CFPB. I'm going to put a link in the chat on our Take Action issue brief about what folks should do. But also steering the conversation back to state law. We still need state laws on this topic of credit reporting and medical debt, because the CFPB's proposed rule, unfortunately, is only going to deal with credit reports for credit. But as folks may know, credit reports also get used by employers and landlords. And so medical debt still could harm renters and workers if it shows up on credit reports for those users. And so we need state laws to protect consumers holistically. Plus, this is a proposed rule. It's got to get over the finish line. It's got to it's got to survive court challenges, which is going to be a problem because as folks might know, a lot of the Biden administration's rules are being challenged in the Fifth Circuit and Texas, where industry is having a lot of luck. So we need state laws. But we don't need just state laws on credit reporting medical debt, important as that may be. We need state laws to protect patients like blood cancer patients holistically from the harms of medical debt. And states can do a lot on this topic. So as you probably know, there are some protections for medical debt in the Affordable Care Act. They only apply to nonprofit hospitals. They require financial assistance, but don't set any minimum amount of financial assistance. And most importantly, if a nonprofit hospital doesn't really comply, like doesn't tell the patient about financial assistance, there's not much the patient can do about it. So state law can fill in all those gaps, and that's what our model law does. And I'll put a link to the model law in the chat as well later. So for example, it fills in one gap by allowing consumers to enforce their right to financial assistance in court. It sets minimum thresholds for financial assistance, depending on the consumer's or patient's income level. It has protections against certain types of collection tactics for medical debt, like wage garnishment and liens on a home. It includes a ban on credit reporting. And it also applies to not just nonprofit hospitals, but other entities, because as you know, you go to a hospital and you incur a bill, you get a bill from the hospital, but you also might get a bill from the doctor who's an independent contractor. You might get an ambulance bill. You might get a bill from an outpatient center. You might get a facility fee bill. You might get a lot of bills that aren't just nonprofit hospital bills. And so the model law would also apply to these entities. Because as you know, the hospital bill is only one component of the bills the cancer patient faces. So those are some elements of the model law. Portions of it been adopted in various states, or various states have adopted things like minimum thresholds for financial assistance. And if anyone on this webinar is interested, we at NCLC are happy to provide technical assistance. By the way, I should make clear, it wasn't just me who wrote the Model Act. We have a team who works on medical debt issues. And so there were actually 4 of us, and Bernita Hayes of our NCLC leads the team. Thanks.
Yeah, thank you. And I think that's a perfect segue actually to Maanasa, who, I know in your research, you've been really tracking the laws that states are enacting to protect patients from medical debt. So could you talk a little bit about what you're seeing?
Yeah, absolutely. Thank you so much for having me here today. This is such an important topic, and it's been on top of my mind for the last couple of years. And Chichi like set me up perfectly for my answer. So what we did was we wanted to establish a baseline of what states already have in place on their books, and we published a report on this through Commonwealth Fund last September. And we did a 50-state scan to look at the various components of laws that protect patients from medical debt and the negative downstream effects of medical debt. And then we put together a map that we are continuing to update, and there should be an update with new legislation very soon. So just to give you an overview, we looked at 5 essential buckets of state laws, and the first 2 kind of relate to preventing medical debt, patients from incurring medical debt. The second 2 buckets look at protections that protect patients who've already incurred medical debt. And the final bucket, which is not as necessarily as exciting in the policy realm, but is absolutely crucial to ensuring that these protections are enforced, is reporting requirements. So these are the laws that allow regulators to keep tabs on what hospitals are actually doing and if they're complying with the state laws in place. So talking about the first 2 buckets, which target prevention of medical debt from accruing, Chichi already mentioned financial assistance programs are a key measure to protect patients. And as she mentioned, the federal law is not very prescriptive. It's very vague, only applies to nonprofit hospitals. So we have seen in our research that 19 states and DC have set their own more prescriptive financial assistance standards. And a lot of them do extend these requirements to for-profit hospitals as well. So we've seen that many states set minimum eligibility standards. California, for example, requires most hospitals to provide some financial assistance to all patients under 400% of the federal poverty level. Some states also allow patients with heavy out-of-pocket medical expenses to access financial assistance, even if they don't necessarily meet those income requirements, which is, I think, speaks very closely to the kinds of stories that you heard early on during this webinar. And states kind of differ in terms of whether they allow insured patients to access financial assistance, whether they require hospitals to cover all of the care or just discount the amount that they're going to charge patients. They also differ in terms of whether they allow folks who are undocumented immigrants to have access to financial assistance programs. And then there's also significant variance among states in terms of how accessible they make these financial assistance programs. And by this, I mean, the current process in many hospitals, it tends to be very onerous. There's a lot of documentation requirements, a lot of hoops to jump through before you can become eligible for financial assistance. And some states have really jumped in. Oregon comes to mind. They've passed presumptive eligibility requirements, which means that, if a person has already demonstrated their eligibility for certain other needs-based programs, like say SNAP or EBT, they can then become eligible for hospital financial assistance programs without having to go through all of the paperwork and all of the documentation requirements. Some states have limited what kind of asset tests can be conducted and what kinds of incomes can hospitals consider, what kind of paperwork they need to submit. And then some states require, for example, hospitals to make make available to patients application counselors who can kind of guide them through the process of filling out this paperwork. So that's about financial assistance policies. The second bucket that kind of more it's more attenuated, the connection to preventing medical debt, but I think it's still kind of key, is that there are a set of laws that require nonprofit hospitals to provide community benefits. This is kind of a quid pro quo. They get a bunch of tax breaks in terms of income and property taxes, and both federal and state governments in many cases require nonprofit hospitals to demonstrate that they're providing certain benefits to the community in return for receiving these tax breaks. So these benefits are sort of a broader category that can include financial assistance, but they can also address some community level commitments, such as addressing lack of access to food, housing. And in the long run, the idea is that these kinds of investments can reduce medical debt burden by generally improving population health and improving the financial stability of a community. So we saw that 27 states have their own state level community benefit requirements, but very, very few of these states actually set minimum quantitative standards for how much hospitals have to spend on community benefits. So in most states, it's very wishy-washy. But there are some states like Illinois, for example, that requires nonprofit hospitals to spend whatever amount their property tax liability would have been on community benefits. And then now moving on to policies that can help patients who've already incurred medical debt. We looked at two separate buckets here. First is regulating billing and collections processes. Like Gigi mentioned, a lot of the times, your patients are just handed off to debt collectors who can then take on, can conduct what are called extraordinary collections actions, like selling the medical debt, reporting it to a credit reporting agency, placing a lien, foreclosing on a home, garnishing wages. Under the federal law, before a nonprofit can initiate any of these actions, hospitals have to wait 120 days from the day of providing the first bill and provide patients a 30-day notice before initiating that extraordinary collection action. So I'm going to point out that it does not actually prohibit the use of any of these actions. What they do is just simply create certain speed bumps along the process. So states have kind of jumped in, and some of them have really limited what hospitals can do on this front. First of all, we've seen some states outright prohibit the placing of liens, foreclosing on homes. We've seen, heightened notice and waiting period requirements, and a requirement that hospitals screen patients for eligibility for financial assistance before they can conduct any of these extraordinary collections actions. On the billing side, there are some states that have limited the interest on medical debt, which can really prevent the snowballing of these amounts. Arizona comes to mind. They passed a ballot measure to limit the interest on medical debt to 3%. Some states have also required hospitals to provide payment plans, for example, and really limited how much they can charge monthly on these payment plans. Colorado is probably one of the most advanced states on this front. They allow hospitals to only charge up to 4% of patients' monthly gross income for these payment plans. And then, most importantly, after the 36 months of payment, they require the hospital to discharge the debt, which then significantly limits the patient's exposure to this medical debt. And then finally, as I mentioned earlier, reporting requirements are really what makes everything tick. These protections are only as good as they're being enforced. And Gigi mentioned that the private right of action could be a very useful mechanism, but most states do not really have this available to their patients, and hopefully that changes soon. But currently, as it is, state regulators are left with monitoring what hospitals have been up to and ensuring that they're complying with these state laws. And but unfortunately, most states' reporting requirements really don't allow for that kind of proactive oversight, because they tend to be kind of vague and ask for only information like total dollar amount spent on financial assistance, which really doesn't give them a sense of how a hospital is complying and how well it's complying with the requirement, and how many people they're serving. So So I think states have a lot of avenues to act here. And then I know that we're going to go into this a little bit more. We've seen that, beyond the baseline that we established last September, we've seen states, continue to act and build upon those protections over the last year. And we're excited to see this momentum, and would love to discuss it going forward.
Great, thank you. And thank you, everybody. I think that's all really helpful. Context and setup for the rest of our conversation. I want to invite my colleague, Brianna Wilson, to join us now. Brianna is our Director of Advocacy Communications here at LLS, and she's going to help lead us in the Q&A, because we have a lot of questions that have been coming in while we've been talking. So over to you, Bri.
Thanks. Thanks again to all our panelists. Please feel free, audience, to keep submitting questions, and we'll get to as many as we can. Senator, we'll start with you. Can you talk a little bit about how you're reaching across the aisle to build bipartisan support for your bill?
It's an excellent question. I appreciate that. I always preach to my constituents and to citizens of the state of Indiana that I personally hate politics with a passion. And I did not get into the field to be a politician. I joined the field to be a public servant. My PhD work was focused on nonprofit hospitals and whose interest do they advance? Is it their financial interest or the interest of the patients who they serve? So the passion was there prior to getting elected. And my message to my colleagues has always been focused on asking the question of who benefits from these policies? Who benefits when someone's credit report is damaged? Who benefits when someone's wages are garnished? Who benefits when someone's home is foreclosed on? Does the state of Indiana benefit? Do the citizens and the taxpayers benefit? So I was successful in over the last 4 years in building bipartisan relationships, and I was honored to receive the Civility Award nominated by my Republican and Democratic colleagues for working across the aisle to get things done. I firmly believe this is a form of an economic justice. I don't think that it is fair for our constituents to live at a time when medical costs are extremely high and they can't afford it. And for that reason, I introduced Senate Bill 276, which again, I plan on reintroducing it in January of 2025. That is comprehensive in nature. It includes prohibition on liens towards someone's homes or cars or vehicles. It includes prohibition on reporting medical debt to credit reporting agencies. It includes requirements for hospitals to be sure that they post their financial policies of whether it's charitable contributions or financial assistance, and communicate the cost of procedures before a procedure is delivered when possible. And also it regulates the interest that could be imposed on some of the pending payments. And it's also one more important piece that was not mentioned that I'm pretty sure it's included in your research. We also define the jurisdiction of the judicial system to be sure that the courts are not authorized and do not have the jurisdiction to act on garnishment or lien claims against individuals with medical debt up to a certain procedure. So to conclude on that note, I think as one proverb once said, you might have 1,000 problems in your life, and then you get a health problem, then you only have one problem. If you have one health problem, then that becomes the focus of your entire life. It could deplete your life earnings and savings. It could put you on the street to become an unsheltered neighbor, and it could significantly impact generations of Hoosiers in our state who will be impacted by such debt. So I urge all of my colleagues across the nation to work in a bipartisan fashion and place the interest of our patients before anything else.
Thank you. That's really helpful. We have another question from Richard. He asks, what would you like primary care physicians to know about patients' medical debt? I think this one might be open to whoever wants to take it.
Noam, I'm wondering, I know you talked to so many different people in your reporting. I wonder if you have any insights on this.
I think there's a really interesting convergence between the sort of primary care agenda in this country and medical debt that actually deserves more attention, because I know a lot of primary care physicians are very, very frustrated by what they see their patients going through, but feel in many cases powerless to stop it. I mean, we know that primary care physicians are not the ones that are driving people to medical bankruptcy, but primary care physicians are oftentimes caught themselves in a system that sort of funnels people into hospitals and other places where they do acquire huge amounts of medical debt. But it's complicated because there's a lot on primary care physicians' plates already, and I know a lot of them are very worried about actually getting pulled into questions about people's insurance design and where they may have to go to get lower priced care. But we could probably have a whole conversation about just this topic. So I'll cut it short by just saying, but I do think by empowering primary care physicians more and making them stronger players in the system, not only does that create better health and lower medical bills, I think it also puts somebody more in the patient's corner in many cases than other providers in our system. And these conversations are starting, although still, I think, in a somewhat nascent place.
Thanks. Anyone else want to jump in on that one before we move to the next question? Okay, moving on. Kathy shares that she recently found out that participation in clinical trials can result in very large expenses for the patient. She says, drug manufacturers need us and we need them. So why are we saddled with these high expenses?
I can start with that one. I think, I think Kathy's right that participation in trials can be really expensive. And actually, the Leukemia and Lymphoma Society did a study just last year, kind of trying to dig into this a little bit better, because in fact, there are policies in place now for just about every type of health coverage that your insurance should be covering your clinical trial participation. Yet we know that's not happening universally, and there are a number of barriers to both accessing the trial, participating in the trial, and then being able to afford the trial if you do get in. So I would say, Kathy, I think we hear you, and it's something that we're continuing to work on and study more. I do not think there is, sadly, a perfect answer at this point, but that ability for folks to be able to access a trial not only improves, right, the medications and the long-term, medical outcomes that we see across our patient populations, but it also improves care today for the folks who need to access that trial for kind of new and innovative care. So, it's an important question. It's a really big priority for organizations like ours. And I think there are lots of contributing factors to what is still a real affordability problem. And Steve, I don't know if you have other thoughts or if others want to jump in here.
You covered everything I was going to say.
Great. Let's move on to the next question. We have a question from a participant who is curious if you can see better outcomes for consumers, like lower rates of debt, less bankruptcy, as a result of increased state protections.
I can take a stab at this one. So we are actually in the process of collaborating with Urban Institute, and they're going to be quantifying the impacts of these various state protections that we discussed today on patient financial health and stability. So not quite looking at health outcomes, but we're at least looking at the piece that looks at their financial stability and whether they end up, filing for bankruptcy and ending up in significant debt. And that report is upcoming.
The other thing I would add is it's not directly responsive to the question, but the CFPB did a bunch of research on medical debt on credit reports. And one of the things they noted is that the credit report showed more medical debt in the South, the southeastern United States. And if you looked at the states that they flagged, you can see some correlation with states that expanded Medicaid versus not.
You hit the exact point that I was just going to hit. With the caveat that correlation is not always causation. I was going to point to that exact study showing, the non-Medicaid expansion states have a real problem here. And I think that problem also highlights, something that we haven't actually discussed here, which is, not every person experiences access to health care equitably, and not every person experiences access to health coverage equitably. And unfortunately, people experience medical debt in different ways depending on, who they are. That CFPB study, this problem in the non-expansion states, really highlights that, For people who are members of, historically marginalized communities, Black Americans, there's a real, significant worsening of the problem here for those groups compared to, some others. And I think, if I could wave my magic wand tomorrow and do, one policy in place to really sort of move the needle on medical debt as a problem in this country, it would be Medicaid expansion. And the only other thing that I would say real quick is, a lot of the state action that we've seen in this area has happened within the last 2 years. So, I'm really excited to see the work, Maanasa, that you and Urban are doing, because I think in a lot of cases, it's been too early for us to, be able to really see or measure any of those impacts. But we're getting there now with some of the states that took earlier actions. We should be able to see, what's working best and how to tweak it to make sure that it works the way that it should.
We have a question here that I think, Noam, you've written about this one. You might be well poised to answer. And I think Chi also would like to answer the question. Melinda is asking about Access One, which claims that they can help patients with a medical bill, but her friend applied and ended up with extra interest fees on top of her medical bills. So can you both speak about that?
Sure. Do you want me to start?
Yeah, go ahead.
Sure. So Access One, for those of you who may not be familiar with it, is a patient financing company, one of a number in this space that now work with medical providers to assume responsibility for essentially lending patients the money to pay their medical bills, usually in some sort of an installment arrangement. People may have heard of Care Credit, which is sort of the market leader in this space. It's a medical credit card. Care Credit is a deferred interest product, which means if you pay off your medical bill in a certain amount of time, there's no interest. But if you miss that window, the interest can be up near 30%. Access One works more directly with hospitals. People sign up for a payment plan. And again, if they miss a payment, they can get stuck in now, since interest rates are relatively high, 11, 12, 14% interest, which can add a substantial amount of interest payment onto an underlying medical debt. So for a number of reasons, which hopefully should be obvious in what I just described to you, these are problematic products that essentially exacerbate medical debt challenges for patients. And it should be noted, I should leave this to Chichi, who probably has more insight into this than I do, but they have gotten the attention of CFPB, who's also looking into this precisely because consumers often don't have the information that they need to make good choices. Is that fair, Chichi?
It is very fair. These medical payment products are really problematic. Access One, and especially Care Credit. I would never recommend Care Credit to pay off a medical bill. Their deferred interest feature, which is they advertise no interest for 1 year, let's say 6 months or 1 year, but actually it's no interest for 6 months or 1 year. But if you don't pay off the entire bill in that 6 months or 1 year, actually interest has been accruing retroactively and will be imposed on the account after the 1 year, the 6 months or 1 year is over. And if you're confused by what I just said, can you imagine a patient who is dealing with medical or dental expenses and has to figure out how to pay for them, how confused they are? Another problematic aspect of medical payment products like Access One and especially Care Credit, or just putting a medical bill on a credit card, is that it no longer shows up as a medical debt on a credit report. It shows up as credit card debt or a lending product. And that means if something bad happens and you can't pay it off, it's not going to be protected by the CFPB's proposed rule on medical debt. And it's going to be, it's going to still show up on your credit report. And, it's still going to affect you all the ways that credit card debt that goes bad can affect you. And, we heard at the beginning in the video, one of the patients talk about how they incurred a lot of credit card debt as a result of their blood cancer. We do see that with patients. A lot of medical debt goes on credit cards. And so one of the things we've been pushing CFPB is to extend these protections to credit card or at least medical credit cards. I would advise the person who asked the question and anyone else who's ended up with one of these products to tell CFPB, file a complaint and tell CFPB about your experience to get them to do something about it. And if I could just add, a 30 seconds worth of remarks, people who have catastrophic illnesses like blood cancer, often they, can't work or out of work for a period of time. It affects the entire family balance sheet, right? And so you need more than just protections for medical debt. You need protections for family finances overall. We have this model bill called the Family Financial Protection Act, or the Debt Collection Fairness Act, which protects a minimum level of assets and incomes for family so that they are not economically devastated by debt collection generally. So it protects a minimum income, assets, equity in a car, equity in a home, because, a family is an economic unit, and you can protect the family from medical debt, and yet it ends up the credit card, or they just can't pay their bills. And you want them to be able to pay the mortgage or the rent and the groceries as well, and to feed their kids.
Thank you. On a related note, someone asked about nonprofit hospitals. Are there any rules about the length of time a patient can pay their bill? This person says, I've been forced into a payment plan that I cannot afford because they only allowed 12 months to pay, and then was sent to collection after those 12 months.
So our model bill would have certain requirements for payment plans, including limiting the interest and the payment amount. So I guess the answer is it depends on your state. There's no overall federal requirements. And I don't know if Professor Kona, if you have a more detailed answer about which states would have, which states have adopted protections around payment plans.
I dropped a link in the chat to our 50-state map, which if you look at the billing and collections tab on that map, you'll be able to see what protections are in place around payment plans in each of the states. So that can probably give you a far more detailed answer than I can probably rattle off in 30 seconds.
Yeah, I think that's right. It really does depend on the state. It also, in many states, I think is going to depend on the hospital or the hospital system, because the state won't have a standard or requirement, which is, I think a big part of why we're talking about these types of policies, right? And having some rules around how, kind of how providers, how hospitals are behaving in this space. I would also say if the person asking is a blood cancer patient or family member looking for support, if you contacting LLS, we're happy to help with that too. We're happy to help you kind of dig in and find the answer.
Thank you. And moving into, we've got about 8 minutes left. We are going to do these next questions rapid fire style, trying to get through as many questions as we can. The first question is for Lucy. Someone asked what LLS is doing about the high cost of drugs, especially since LLS gets support from drug companies. Lucy, can you take that one?
Yeah. So let me say, the out-of-pocket cost that patients are expected to pay is too high, period. For drugs, for medicine, for visiting the doctor, for everything, right? The total cost, the out-of-pocket cost is too high. So LLS has long been focused on reining in the cost of care, and particularly reining in what patients are expected to pay. So when it comes to prescription drug costs, I will flag, we've, for about 10 years, we have been lobbying Congress to reform Medicare Part D to ensure that there is a cap, and that cap is kind of what we call smoothing, right? The cap and smoothing, that it's capped and it's smoothed out across the year. And we were successful just last year in passing that. Finally, that new policy. So if you are, if you have Medicare and you have Part D, you now will have, or going into next year actually, is when it will finally implement, you'll have a cap of $2,000 over the entire year for your medications. We do very similar work across states. We do work on copay caps, oral parity, which over 40 states have passed now, which ensures that the cost of your medication costs the same as if you were receiving chemo in a doctor's office. So there's a variety of policies that we work on that really go at what folks have to pay for the cost of their medications. And maybe you want to rapid fire? Never mind, Brianna, I'll let you go to the next question.
Thank you. Steve, we talked a little bit about this. We saw the exciting news from the CFPB recently to remove medical debt from credit reports. Do you think there's still work for states to do in this space?
So much work. Chi-Chi and Maanasa, highlighted a couple of things. First of all, continuing the credit reporting work to make sure it's applied across, all of the different use case scenarios for, your credit report, not just actually accessing credit, but, rental applications or job applications. But also something that I would highlight here, or I guess here's a short answer to that. Not only can and should states do more, but they should really go bold. I love pointing out that we got, it's one thing to look at polling, it's another thing to look at an election result. And there was a, medical debt ballot initiative in the state of Arizona a couple of years ago now, that passed with something like 70+% of the vote, that had significant overhauls of how that state deals with medical debt. It limited interest rates, it had a bunch of the other protections that have been mentioned here. If you want a really granular, finite, and clear understanding of how the public feels about this, look at that ballot result. In a state like Arizona, that's often a battleground state that I think is really, sort of politically diverse and politically, sort of, right down the center in terms of, where that state falls on the red-blue map. When more than 70% of a state votes in favor of these kind of reforms, that tells me that we really shouldn't be timid here, and there's really an expectation and a demand, for bold action. And the great news there is states have a ton of authority here. There is not a lot of federal preemption on a lot of these issues, the way that we see sometimes with like different kinds of insurance that are regulated federally versus at the state level. States have a lot of opportunity space here, and I think it's really important to seize that.
Thanks, Steve. We have a question from Kayla that I'd like to direct to Noam. I think you've probably come across this a lot in your reporting. Kayla says she lives in Missouri and has ignored all of her medical bills and allowed them to go to debt collectors because she's been so overwhelmed by them. So she's wondering what she can expect. When will they begin wage garnishing? Will it hinder her from buying and selling a new home? Any insights you have on that?
Well, so one of the things that people may not understand about the way medical debt is treated by medical providers, and Chi-Chi, you should jump in here too, because I know you know much more about this than I do, is that providers have an enormous amount of discretion. Even before there was discussion about CFPB or state measures to limit credit reporting, for example, some medical providers didn't do it. There are some medical providers that don't sue their patients. There are some hospitals that will not put liens on their patients' homes. And so a lot depends, unfortunately, or fortunately, I guess, on just where those medical bills come from. And I think, if the CFPB goes forward with limits on credit reporting, maybe that goes into effect next year, assuming it's not held up in litigation. Maybe there's some protections next year on credit reporting. As to sort of more aggressive kinds of collection actions, it's just going to vary depending on where that bill is from.
Thank you. All right, we are really, really going to do rapid fire. We've got about 2 minutes, and I'd like each panelist to answer this question. The question is, looking forward in terms of medical debt legislation, how optimistic are you? What do you think the landscape looks like in 5 years? So let's start with the Senator, and we'll move along from there.
Thank you. I'm always optimistic and always hopeful. We can't afford pessimism or the idea that we can't pass legislation. So I'm extremely optimistic. I'll be working hard with my colleagues on this idea, and we hope to pass it in Indiana.
Let's go on to Chi-Chi.
I'm optimistic as well. as I said at the beginning of my remarks, I've been working on this for a very long time. And, medical debt is having a moment right now, and we are seeing a lot of reforms. So I feel like a lot of this work is paying off, and I'm hoping we'll get the credit reporting ban, and we'll get more than that.
Noam, what about you?
Oh, I think it's very exciting what's happening. I mean, there's a lot of stuff happening at the state level, particularly, that I think people may not appreciate, and a surprising amount of it is bipartisan. So I would expect we're going to see more, particularly at the state level.
Great. Let's go to Maanasa, and then Steve, and finally Lucy, who will wrap us up.
Okay, yeah, I echo what everybody else said. I am optimistic. I think it really is having a moment, and Steve is absolutely right. There is a lot of bipartisan consensus around these issues. The one thing I'll say that I recently wrapped up looking at the recent state action that has taken place over the last year since we published our report in September to like June, and not almost all of the protections that we saw really targeted folks who already have medical debt. And we haven't really seen as much movement upstream where you're protecting patients from medical debt, because I imagine that's a little bit more politically contentious to expand these financial assistance programs. But yes, I'm optimistic, but I'm also hoping that folks take on these more upstream measures as well.
Yeah, same. Again, I can't help but highlight that Arizona ballot initiative result again. I think if you want just such a clear indication of where the country, is on this at this moment, it's right there. And, seeing the action that we've seen and how this is building over the past few years, I'm incredibly excited to keep working on this.
Yeah, I mean, I echo what you've heard from everyone. I think we are having a moment in the states, and, the truth is states are the laboratory of democracy, right? That saying is true. If I were to predict or crystal ball what happens in 5 years, I think we're going to have real movement at the federal level. And I hope I'm not, knock on wood, not jinxing anything, but I think we're going to have, I think this is only going to continue, this momentum. So maybe we are at time, we are over time. I want to thank our panelists again so much for your time, your expertise, and your leadership. We at LLS are so thankful to have you as our partners. And again, for folks who are looking for support or are looking to engage, please do contact us. We are happy to work with you. And with that, I think I'll close us out. So take care, everyone. Thank you.